Hello class, Dr. Sclafani here. I'm the lab assistant for this imaging class and am a contributing faculty member to the University of St. Augustine, in addition to practicing as a sports physical therapist at the Cleveland Clinic, Florida. We're going to cover several topics today related to the foot and ankle. These particular pathologies are commonly assessed through various imaging modalities. The first topic we're going to cover today will be ankle syndesmosis injuries. Although common in the sports medicine world, they can also be encountered in the orthopedic trauma setting. The primary mechanism of injury is a strong ankle eversion and/or dorsiflexion type injury. Remember that the ankle syndesmosis is generally a referral to the distal interosseous membrane between the tibia and fibula, as well as a few ligaments that we'll talk about in detail in a moment. So we've already touched on the various mechanisms for an ankle syndesmosis, which again are listed here. Remember that the ankle joint is often described as a mortise, where the talus fits into the distal tibia and fibula, as I circled in red on the X-ray. The bottom left image demonstrates ankle external rotation, resulting in a gapping between the distal tibia and the fibula. The bottom right image demonstrate excessive dorsiflexion of the talus into the distal fibula and tibia, resulting in more of a spreading type injury of the distal tibia and fibula. These are the two most common X-ray views taken when there is a suspected ankle syndesmosis injury. The AP and the mortise views may look similar, but have different diagnostic imaging purposes that we'll touch on soon. The AP view is routinely done in a standard ankle series of X-ray orders. However, the mortise view is a special order view and is oftentimes done to specifically investigate a suspected syndesmosis injury. As shown on the right, the mortise view X-ray is performed with the leg internally rotated 15 to 20 degrees so that the X-ray beam is perpendicular to the intermalleolar line. Some very traumatic ankle syndesmosis injuries are very obvious both on clinical examination and on imaging. However, some injuries to this area may be a bit more subtle, and attempting to determine the extent of the injury can help to determine how the patient is managed clinically. One measure that is useful for us is the tibiofibular clear space, which is defined as the distance between the lateral border of the posterior tibial prominence and the medial border of the fibula. In the left drawing, which is a mortise view, Point 3 represents the lateral border of the posterior tibial prominence. Point 2 represents the medial border of the distal fibula. So the tibiofibular clear space is measured between points 2 and 3 on this diagram. Bear in mind that this measurement, as well as the other measurements we're going to talk about, is taken 1 centimeter above the tibial plafond, or that superior joint space on the tibia over the talus. The reported normal value for the tibiofibular clear space is somewhere less than 6 millimeters. Here we can see how much easier it is to visualize that tibiofibular clear space on a mortise radiograph as compared to the AP view. Remember that a mortise view is not typically included in a standard X-ray series, but usually has to be specifically requested. These are films taken of an uninjured ankle, as the tibiofibular clear space is measured at 5 millimeters, which is less than the normal 6 millimeters. Here we can see an example of a stress X-ray aimed to reproduce the mechanism of injury to examine any potential instability that might be present. The injured ankle is on the left, while the uninjured ankle is on the right. In addition to the increased tibiofibular clear space, which they labeled as a tib-fib interval, we can also look medially at the increased space between the medial malleolus and the medial talus. The next measurement that we're going to discuss is tibiofibular overlap. This is defined as the maximal overlap between the medial border of the distal fibula and the lateral border of the anterior distal tibial prominence. That sounds like a mouthful, but when you look at it on an X-ray, it's really not as confusing as it sounds. In the drawing on the left, we can measure from point 2, which is the most lateral point on the anterior distal tibia, to point 1, which is the medial edge of the fibula. Rather than looking for the space between these two structures, as we did in the clear space that we just discussed, we're looking now for how much of an overlap there is between the tibia and fibula. Just like the tibiofibular clear space, the tibiofibular overlap is measured 1 centimeter above the tibial plafond. The normal values are recorded on this slide as well, and keep in mind that a higher measurement is desired since it indicates more of an overlap between the distal fibula and tibia. So this is a mortise view with a tibiofibular overlap measured as 17 millimeters, which is considered normal because it's more than 1 millimeter. Here we can see two different patients that suffered a syndesmosis injury. Due to the separation that occurs between the distal tibia and fibula in this type of injury, there is no longer much of an overlap between these two bony structures. Remember that in ankle syndesmosis injury, we want an overlap to occur between the distal tibia and fibula. Keep in mind that these are more obvious frank syndesmosis injuries and that a more subtle injury may necessitate a more specific radiographic measurement of the tibiofibular overlap. These next two slides show how we can tie everything together that we've talked about so far when looking at x-rays for ankle syndesmosis injuries. Sometimes it's nice to compare everything side by side, especially when looking at an AP and mortise view. These are images of a patient who suffered an ankle eversion injury, resulting in an injury to the ankle syndesmosis. In addition to the decreased tibiofibular overlap and clear space, another clue can be the increased medial clear space from the talus being forced to wedge itself within the mortise and forming a spreading type of injury. So far we've looked at bony alignment and relationships on x-rays. These are a list of some of the ligaments and soft tissue structures that we're going to look at on an MRI. So here's a lateral view of the ankle where I've circled where the anterior and posterior inferior tibiofibular ligaments are located. Notice how they're more superior than the anterior to talofibular ligament, oftentimes abbreviated ATFL, which is oftentimes injured in our traditional lateral ankle sprain. Here's a T2 weighted MRI of a 40-year-old male who suffered a right ankle injury. The arrow represents to the region where the contrast dye has extended more than 2 centimeters superiorly into the tibiofibular joint recess. So this suggests a potentially increased tibiofibular clear space that we discussed earlier when discussing ankle x-rays. Unrelated to today's discussion, there is also a talar dome osteochondral lesion as indicated by the arrowhead. This is an axial T1 MRI of the left ankle. Axial views of the ankle can take some getting used to, so let's pause to orient ourselves to this view. Remember, we're looking at the ankle joint from a top-down or superior to inferior approach. So while you're sitting at your desk, if you look straight down towards the floor with your knees bent at 90 degrees to your heel, you'll be in the same view as this ankle MRI. So the top view of the screen is usually anterior towards your toes, and the bottom of the screen is posterior towards your Achilles tendon. The top arrowhead in the labeled structures show a normal anterior-inferior tibiofibular ligament. The bottom arrowhead points to a normal posterior-inferior tibiofibular ligament. Notice how they each have more of a band-like appearance. Here are two more axial MRI images of an 18-year-old female who suffered an acute injury to the anterior-inferior tibiofibular ligament. Notice in the T1 image on the left how the ligament is thickened, is irregular, and has a small discontinuity where the arrow is pointing to. In the T2 image on the right, we can see a little bit more edema in and around the AITFL as indicated by the arrow. Here we see a T2 axial MRI of a 17-year-old hockey goalie who sustained an acute injury to the posterior inferior tibiofibular ligament, where the arrow is pointing to. Notice how edema has an increased white signal in a T2 weighted image. The arrow is pointing to a thickened and edematous PITFL. The arrow head is pointing to bone marrow edema about the posterolateral distal tibia, suggesting some type of instability event around the syndesmosis. We can't talk about ankle syndesmosis injuries without at least mentioning Mason-New fractures. So this type of injury is seen with a strong ankle pronation external rotation injury mechanism, the same as the other ankle syndesmosis injuries we've been talking about so far. During this type of injury, force is transmitted proximally along the interosseous membrane, where the proximal third of the fibula is too weak to accommodate this force transmission and thus fractures. These x-rays show a clear pattern between an ankle syndesmosis injury and a more superior proximal fibular fracture. The red arrows in both of these x-rays show the separation of the mortise in similar patterns that we've discussed so far today. The yellow arrow on the left x-ray and the blue arrow on the right x-ray demonstrate the Mason-New fracture at the proximal fibula. Let's transition into a topic that is very common in the outpatient orthopedic world, Achilles tendinopathy. Don't forget, when we talk about chronic tendon issues, it is most prudent to use the term tendinopathy rather than simply tendinitis. With chronic repeated stress that the tendon is not able to accommodate, small microtears appear within the tendon fibers. These small microtears along the tendon fibers oftentimes result in disorganized repair and thus various morphological changes that are evident on imaging modalities, which we'll look at here shortly. Let's start with looking at ultrasound images for ankle tendinopathy. These pictures are taken directly from an article out of Physical Therapy and Sport that was recently published in December 2018 that compared ultrasound images of Achilles tendon in patients with and without Achilles tendinopathy. In this picture, we can see the transducer placement during ultrasound evaluation of the tendon thickness on the left and cross-sectional area on the right. This shows how a longitudinal image is obtained using the ultrasound transducer. A healthy Achilles tendon will have well-organized and parallel collagen fibers as seen here. Let's focus on the top of this drawing where we can see a long longitudinal strip of ultrasound to investigate the Achilles tendon. This is performed by taking the transducer and literally sweeping it along the length of the tendon in a superior direction, resulting in a sort of widescreen view along the tendon. These images are thus labeled longitudinal and provide a north-south superior-inferior view of the tendon. If we focus along the bottom three squares of this image, we can see how we get more of a bisection of the Achilles tendon looking left and right. As we'll see in a minute, these transverse images are useful when looking at the cross-sectional area of the tendon at different points along the tendon superior and inferiorly. Here we can see how a transverse image is obtained using the ultrasound transducer. Again, this is looking at the tendon from left to right. Let's first take a look at the top two images labeled A and B. These are two transverse images like what we just saw on the last slide, bisecting the tendon and looking at it from left to right. I drew red lines on these images to show the difference in cross-sectional area. In figure A on the left, we can see how the tendon has a nice rectangular shape that fits between the two red lines and also has a nice parallel fiber running left to right. In figure B on the right, we can see how the tendon starts to take more of a rounded shape that extends outside of the red lines, indicative of a thickened tendon. In addition, notice how the fibers are not as parallel, but are more disorganized and heterogeneous. Both this thickened and heterogeneous appearance are classical signs of tendinopathy. The bottom image, labeled C, is a longitudinal view of the same tendon. Here we can see the arrowheads are able to identify the thickened and more disorganized area that coincides with figure B. Here's another longitudinal ultrasound image of the Achilles tendon. I drew yellow arrows pointing to the areas that look like black holes in the tendon, which is demonstrating tendinosis with a small intratendinous rupture. Sometimes this gets referred to as a partial tear of the Achilles tendon by orthopedic clinicians and when discussing this with a patient. Here we can see two longitudinal ultrasound images. The left image labeled A demonstrates a normal Achilles tendon. The right image labeled C shows an increase in the cross-sectional area of the Achilles tendon as well as mild tendinosis along the inferior margin, which we can see how the tendon fibers are no longer organized in a smooth parallel fashion. Here are two transverse images of the Achilles tendon. So I drew red dotted lines on each image to show the margins of the Achilles tendon. The image on the left is of a normal Achilles tendon displaying characteristics that we've seen previously, a more rectangular shape overall with smooth horizontal parallel fibers. The image on the right reveals tendinopathy, where we can see an increase in the cross-sectional area of the tendon, making this portion of the Achilles appear very circular and outside the typical medial-lateral margins. This table was taken from the article I mentioned previously that was published in Physical Therapy and Sport in December 2018, investigating ultrasound images of 143 subjects, split between healthy controls and those who were currently experiencing mid-portion Achilles tendinopathy for at least 3 months. This just puts some numbers behind what we just touched on. Those patients with Achilles tendinopathy will demonstrate an increase in the cross-sectional area, as we saw in a longitudinal image, and the thickness of the image as we saw in a transverse image. Let's transition now to investigation of the Achilles tendon using MRI. Here we can see a normal Achilles tendon using both a T1 on the left and a T2 weighted MRI on the right. Note how smooth and parallel the tendon fibers appear here in a normal Achilles. Here we can see two MR images of a patient with Achilles tendinopathy. Notice how the arrows are pointing to thickened regions within the tendon. Again, we can appreciate the increase in tendon cross-sectional area indicative of tendinopathy. Also, observe the brightened signal in the right T2 image, likely indicative of a mild inflammatory response within the tendon fibers. We've been talking so far a lot about Achilles tendinopathy, but I thought I would touch on imaging for an Achilles tendon rupture. For a suspected full-thickness tendon rupture, ultrasound is not typically used in the clinic because the field of view can be a little limited and it can be difficult to investigate on any other potential pathologies since ruptures typically occur in a more traumatic setting. Sometimes sports medicine clinicians may use a portable ultrasound unit on the sideline since it's fast and easy. But even then, the patient will typically undergo an MRI as soon as possible in the clinic. This was a meta-analysis published by the British Journal of Sports Medicine in 2016. The authors reported a risk ratio of asymptomatic patients with abnormal ultrasound imaging findings developing Achilles tendinopathy. They defined this risk ratio as 7.33. Let's explore the implication of these results in greater depth. So here's the forest plot the authors published demonstrating a risk ratio of 7.33 for future development of Achilles tendinopathy with ultrasound abnormalities at baseline. So what do these results mean exactly? Basically, the authors of these various studies looked at a bunch of athletes' Achilles tendons on ultrasound before their particular season started. The athletes who had any abnormal findings on these preseason ultrasound images were found through this meta-analysis to be 7.33 times more likely to develop Achilles tendinopathy at some point during the season than their other teammates who had normal ultrasound images of the Achilles tendon preseason. So based off the results of this meta-analysis, it may seem tempting to just go ahead and perform a quick ultrasound on various superficial tendons like the Achilles or patellar tendon on every athlete during the preseason, right? Because if you can supposedly predict whether an athlete is at risk for an injury, you should just go ahead and be proactive about this rather than trying to be reactive to an injury that pops up in the middle of the season, right? Maybe not. Let's use Richie McCaw as a hypothetical scenario. He's the MVP flanker for the New Zealand rugby team during the Rugby World Cup a few years ago. He was one of the driving forces for the team's overall success throughout the World Cup. So you perform an ultrasound on his Achilles tendon preseason and find some things that look fishy for this particular, his tendon and potential tendinopathy. You remember the results of this meta-analysis stating that he now has a 7.33 times risk of developing Achilles tendinopathy, so you go ahead and take preventative measures to treat his Achilles tendon. So Richie McCaw never has any issues with his Achilles tendon, and he helps to lead the New Zealand All Blacks to a Rugby World Cup championship, hoist the trophy in the air with the rest of the team, and all is well. So that's one scenario of how that could all play out, but this probably really isn't likely. One thing to consider is that performing imaging, even ultrasound, is still time-consuming, especially for an entire team of athletes who aren't even in any pain. Also, what do you do if you have a starter who has no symptoms at all, and now you tell them that you saw some potential issues on an ultrasound image that may or may not give them trouble later on in the season? There can be some serious psychological belief factors that may play out in this situation, as we've seen in patients who hang their hat on spine MRIs with or without symptoms. Planting that seed in a patient's mind can be pretty detrimental. So now you've used up time and resources to perform these preseason or preventative scans and planted a potential shadow of a doubt in their minds that can throw them off their game and may result in a potential injury. I don't want to sound like I'm saying that this article was a bad one. In fact, it's quite the opposite. I think injury risk reduction and prediction strategies are paramount both in the orthopedic and sports medicine worlds. I just want you guys to be able to critically think about how you might or might not use these studies and strategies in the clinic with your own patients. Let's change gears now to another very common pathology that we see in the outpatient world, plantar fasciitis. Remember that the plantar fascia originates at the medial tubercle of the calcaneus and fans out along the sole of the foot. The most common pathological site for patients with plantar fascia pain is the enthesis at the calcaneus, so investigating this junction will be important. Here we can see where the ultrasound transducer is placed and the outlines of healthy plantar fascia and its insertion within the calcaneus. This is another ultrasound image of a normal, healthy plantar fascia. Apologies about the English translated spelling of the calcaneus in this labeled figure, but I liked how this image colored in both the plantar fascia and the calcaneus. Here's another ultrasound of a normal, healthy plantar fascia. I outlined in red the margins of the plantar fascia, so we can see how the plantar fascia fibers are nice and parallel. This demonstrates how a corticosteroid injection is performed, with the needle represented by the arrow. Again, there is typically pathology at the plantar fascia enthesis at the medial tubercle of the calcaneus, so it's near this junction that injections are oftentimes performed. Until the more recent boom of utilizing musculoskeletal ultrasound, MRI was always considered the gold standard for orthopedic imaging. Here are some diagnostic stats comparing ultrasound and MRI. Keep in mind that ultrasound has a pretty steep learning curve, so it can sometimes be difficult to obtain precise diagnostic stats for this particular imaging modality. Just take these numbers with a grain of salt, is all I'm saying. These are some of the common findings on ultrasound in patients with plantar fasciitis. It's been reported that the thickness of the plantar fascia is more clinically indicative of pathology, especially when the thickness is measured to be greater than 4 millimeters. Even though a thickness of 4 millimeters or more is widely accepted as pathological in the literature, remember that there are exceptions to this on both sides of the spectrum. Some patients have symptoms of plantar fasciitis with thinner ultrasound measurements less than 4 millimeters, and this could be due to tissue sensitivity or some other mechanisms. On the opposite end of the spectrum, we've also seen some patients who don't have any symptoms at all, but have plantar fascia measurements greater than 4 millimeters. One explanation for this is Wolff's Law. So larger or more overweight individuals may naturally stress their plantar fascia in a normal environment, causing the tissue to respond and adapt to this by thickening to accommodate. This can be one explanation for a plantar fascia measurement greater than 4 millimeters in an asymptomatic patient. Here's another example of the increased thickness along the plantar fascia that we've seen in patients with plantar fasciitis. Sometimes the repeated traction from the plantar fascia enthesis along the calcaneus results in an osteophyte or bone spur to form, which I've circled and labeled in yellow. Let's take another look at asymptomatic versus symptomatic images. The image on the left of the screen shows evidence of plantar fasciitis. We can again appreciate the thickened appearance, and another calcaneal osteophyte is circled in green. The last topic we're going to discuss today is medial tibial stress syndrome, oftentimes abbreviated MTSS. The current hypothesis behind MTSS is a pulling of the medial aspect of the soleus along its attachment to the middle third of the tibia. Some have described this as a precursor to a tibial stress fracture. Here's just another drawing demonstrating the various muscular attachments to the medial aspect of the tibia that may generate some type of bony stress. This is a special order series on an MRI labeled as a tibia-fibular view that runs from the tibiofemoral joint to the talocrural joint. This is a coronal view T2 weighted tib-fib MRI. Remember on a T2 MRI that bones will appear dark, allowing for any inflammation to light up. Here we see medial tibial stress syndrome on both tibias, as well as some effusion that has permeated medially into the soleus medial tibial interface. This is a table taken from an article published in 2005 comparing MRI, CT, and bone scans when investigating medial tibial stress syndrome. It's important to note how MRI is the best imaging modality with positive predictive values recorded at 100%. X-rays are typically taken as part of a routine exam in the orthopedist's office. Like we've seen in several pathologies in this class, X-ray may not show much until the condition progresses pretty far. This is the case with medial tibial stress syndrome as well. The two red arrows show some evidence of bony stress and cortical reaction. We already mentioned earlier about how bone scans aren't the best imaging modality anymore for certain pathologies, but I thought I would include bone scans of a patient with medial tibial stress syndrome. As we've mentioned previously in this class, bone scans are going out of vogue since they expose the patient to a lot of radiation and oftentimes are unable to discern chronicity. Here's another coronal T2 tib-fib MRI. Again, what's nice about a T2 MRI is that any inflammation will light up nicely and white against the dark contrast of bones. Here we can see a vertical white streak along the distal to middle third of both tibiae, indicating periosteal edema. Here's another slightly differently weighted coronal T2 tib-fib MRI. We can see the fluid inflammation that will appear white against the darker shaded bones. The patient's right tibia shows a more advanced progression of bony stress than the previous slide with edema that has started to penetrate deeper through the bone. Here are two more coronal view tib-fib MR images that allow us to compare a T1 versus a T2 weighted MRI. On the left image, we see a T1 MRI where the bone appears bright and any loss of structural integrity will start to appear slightly black, as we see pretty much right in the center of the tibia on the medial side. On the right image, we see a T2 MRI where the bone is dark and any edema is bright. Now we can appreciate a bit more the extent of the injury and how widespread and deep the loss of structural integrity is of the bone. Back in 1995, Frederickson et al. Published an article in the American Journal of Sports Medicine that graded medial tibial stress syndrome severity using MR images. In 2012, Kajowski et al. Validated this classification system in an article published in the American Journal of Röntgenology. This particular diagram represents an axial view of the tibia, so let's explore this further. Admittedly, axial views of the tibia, fibula, and ankle are initially harder to assess until you get a feel for them. Remember that the axial view images are sliced perpendicular to the tibia, which allows us to get a cross-sectional view of this area. So here we have an axial view T2 tib-fib MRI. Again, things that are water-based, like edema, will show up bright on a T2 weighted MRI. So on the patient's left tibia, we can start to see some bony edema that is starting to permeate through the periosteum into the marrow. This would likely be labeled as a grade 2 based on the Frederickson classification system that we discussed earlier. MSK ultrasounds are frequently not used in the clinic for suspected medial tibial stress syndrome, since the view can be a bit narrower than what we've seen in previous slides on an MRI, but I thought it'd be worth briefly looking at since it's such an up-and-coming imaging modality due to its portability and typically faster scan times than an MRI. So here's an example of the periosteal edema that we can see in this symptomatic patient on the left image. Notice how the periosteum becomes irregular with almost a wavy appearance rather than the smooth, straight edges found on the right image in an asymptomatic patient. So this would likely be classified as a Frederickson grade 1. So these are my references, and thanks guys for listening.